Hello everyone, my name is Scott, and today we're going to be talking about cardiac dysrhythmias. And the way that this lecture is going to be structured is we're going to start off with basic concepts such as the cardiac action potential and the cardiac conduction system, and then move on to more complex topics such as the rhythms themselves and actually being able to identify them, and maybe even talk about some potential treatments. And the reason why I wanted to structure the lecture this way is so that we have this foundational knowledge to then discuss rhythms, because if you don't understand how cardiac action potentials work and the cardiac conduction system works, then you're not going to be able to understand the pathophysiology behind cardiac dysrhythmias and the associated treatments and how those alter cardiac conduction as well. And before we dive into the topics at hand, I just wanted to preface this whole lecture by saying I chose to talk about cardiac dysrhythmias because when I was going through cardiology and learning about cardiology as a paramedic student, I had a lot of confusion and a lot of unanswered questions. I felt like that I had to go research on my own time outside of school. So hopefully with the information I'm bringing you today, if you're anything like me and you're a student, this video and the information I'm giving you is going to give you more clarity on your questions and hopefully help you progress as a paramedic or a pre-hospital provider at any level. So anyways, let's get right into it. All right, so let's dive right into the cardiac conduction system. So the cardiac conduction system starts with what's called as pacemaker cells and/or nodal tissue. And these are specialized cardiac myocytes that can generate their own impulse. And that specific concept is called automaticity. Automaticity, again, grants this nodal tissue and/or pacemaker cells, specialized cardiac myocytes, the ability to generate their own electrical impulse. So this is what starts the cardiac conduction system right here in the sinoatrial node with this group of nodal tissue or pacemaker cells, right? So they generate an action potential. An action potential, again, is an electrical signal. So, right, they generate this action potential. And what this action potential and or electrical signal does is it goes through what's called as the intranodal tracts. And normally, I know it's not showing it in this diagram, there would be these things called intranodal tracts, which lead to the AV node. And as this electrical impulse is going through these intranodal tracts, right here, this intranodal tract, this would be Bachman's bundle, This isn't an intranodal tract, but it's just another extension of nodal tissue into the left atria, right? And so as this electrical impulse goes down all of these different tracts, it depolarizes both the right and left atria. Basically what this means is for all these cardiac myocytes that this tissue goes through and the signal goes through, it means that they're becoming more positive, right? And what that means is they're stimulated with energy, essentially, right? So, and that's what depolarization is. So when all of this is depolarized, the left and right atria all becomes depolarized. What that causes is atrial contraction. And what you see on your EKG strip and how you identify atrial contraction on the EKG strip, that's your P wave, right? So as all of this depolarizes, left and right atria, the conduction goes through the right atria and the left atria. As it depolarizes, it causes atrial contraction, and that would be your little blip. Your first blip on your EKG strip or in your QRS complex is your P wave, right? So after you get your P wave and your and the electrical signaling goes through all of this tissue, it meets the AV node, right? And when the action potential gets to the AV node, what's going to happen is there's going to be a little bit of a pause, right? And so that pause, what it's going to look like on your EKG. I know I keep referencing an EKG strip, but this is what we're going to be talking about as far as cardiac dysrhythmia, so I might as well make it make sense in that point, so you know what the hell you're looking at, right? So anyways, this impulse is going to get to this AV node here, and so there's going to be a little bit of a pause, and that's going to be your PR segment. Your PR segment is going to be a little section back on the isoelectric line between your P wave and your first downward deflection of your P wave, right? So after this conduction meets the AV node, it's going to move into another structure called the bundle of His, right? So your bundle of His is then going to lead into what's called as the left and right bundle branches. And this nodal tissue is going to go through and supply signaling to all of these cardiac myocytes in the left and right ventricles, right? And so the signal is going to keep going through the left and right bundle branches and down into what's called is the Purkinje fibers. And the Purkinje fibers are going to be the last structure that this action potential or electrical signaling is going to meet. And once all of this, again, becomes more positive, right? We're talking about everything becoming more positive as an electrical signal is created. All of these cardiac myocytes are becoming more positive, right? That's going to cause... that is depolarization again, as we talked about, and that's going to cause ventricular contraction. And so that's going to, and how you see ventricular contraction in reference to your 12 lead, that's going to be your big QRS, your big spike, essentially. The QRS is ventricular depolarization, which signals ventricular contraction, right? And then all of this tissue, right, this tissue is going to repolarize. Right. So what repolarization essentially is it means that cardiac tissue is going to become more negative, and it's going to go back towards what it's called as its resting membrane potential, which is inherently negative. Resting membrane potential is about negative 70 millivolts. So it's going to start becoming more negative again, right? And once it becomes more negative and it repolarizes, you're going to get ventricular repolarization is going to create what's called as the T wave on your EKG strip, right? It's going to be another upward deflection. And you may be thinking, why is there another upward deflection if it's becoming more negative? When it go down, that just, makes sense. Because like your QRS, that's everything becoming more positive, right? It's depolarizing and it's an upward deflection. And the reason for that, the reason why it's in the same direction, even though it's becoming more negative, is because of the way your 12 lead setup and the charges of the electrodes, right? So in your top right electrode, or your RA, right arm, up there, that electrical signal up there is going to be negative, right? And down here, this electrode down here, that's going to be positive, your lower left one, right? So that signal is more positive down here and more negative up here, right? And so as that positive charge moves towards your positive electrode down here, that's when you're going to get like an upward QRS deflection, an upward P wave. That's why those are up, right? So and then when you're repolarizing and everything's becoming more negative, and that signal is going to be moving back this way, right? And then so negative signal, this negative signal is going back towards this negative electrode over here, and that's going to give you another upward deflection, right? Positive, you're going to get an upward deflection. Negative, you're also going to get an upward deflection, right? And if it was the opposite, then if it was negative to positive, you get a downward deflection. Does that make if that makes any sense, right? And that's also why your QRS, it doesn't just keep going up because it's getting more positive. It goes down again, right? Because all of this tissue, right, bundle branches going into your Purkinje fibers, right, that's becoming more positive. The signal moves down here, right? But then it has to turn and innervate the rest, and it has to go through the rest of the Purkinje fibers, right? So that positive signal is going to go back towards this negative signal here, a negative electrode, and it's going to cause that downward deflection. So that's why your S wave is going downwards, right? That's why it starts deflecting downwards. Anyways, hopefully that's going to make looking at an EKG make a little bit more sense. But still, before we get into dysrhythmias themselves, I'm going to blow up an image of a cardiac action potential, and we're going to talk about it a little bit more because I think it's really important that we talk about it just a little bit more, because it's going to make the drugs and the treatments that we talk about make more sense. So now that we understand how cardiac conduction works and how electricity moves through the heart, where those impulses go and what they mean and what they cause as far as our diagnostic tools and how we monitor people's cardiac status, let's move on to actually taking a look at the cardiac action potential itself in a cell, and let's blow it up so we can see what's going on inside. So right here is your resting membrane potential. So this is what the charge of the cell is at rest, when nothing's happening. It's not depolarizing, it's not repolarizing, it's just at rest. So right here it's going to be negative. It's about negative 90 millivolts when it's at rest. That's the resting membrane potential. So when an impulse from another myocyte, or from another myocyte, metal tissue or whatever, reaches this cell, right, and this impulse is moving through the cell,
this is what happens, right? So you get an opening of sodium channels and you get an opening of calcium channels. And the first calcium channel to open, that's an L-type calcium channel, but that's not really pertinent. But there are two different calcium channels that open up throughout the course of the cardiac action potential. I thought I would mention it. But anyways, you have calcium channels that open and sodium channels that open. And the important takeaway from this concept here is that positive ions are flowing into the cell. And this is changing this potential, this electrical charge of the cell, and it's making it more positive. More positive ions in, charge is becoming more positive. This right here, this first phase of the opening of the sodium channels, this is phase 0. So once these sodium channels close off, calcium channels are still open. They're still flooding the cell with positive ions, right? So it's going to become a little bit more positive, and then eventually, what's going to happen here is potassium channels are going to open to balance this, right? And this is when you get the second type of calcium channels that open, right? And that's going to be actually in the cell. The sarcoplasmic reticulum specifically is going to open up, and this is where you're going to get that other influx of ions, all right? And so you have calcium ions flowing into the cell, potassium ions leaving the cell, right? And what that means is because potassium is a positively charged ion, and you have a positively charged ion that's in the cell moving out of the cell, it's making the cell more negative. So these two things right here are balancing it out. Positive ions in, positive ions out. So you get phase 2, and this is where you get a plateau because they're both balancing each other out a little bit. It's going down a little bit, right? So, and then you get phase 3. And so those calcium channels are going to close up. Potassium's still going to be shooting out. And this is when the cell starts repolarizing or becoming more negative because it's just potassium leaving the cell, just positively charged ions leaving the cell, making it more negative. Less positivity, more negativity, right? So, and then this is going to keep happening until the cell becomes actually below its resting membrane potential. It's going to hyperpolarize. It's going to become so depolarized that it's going to shoot under the resting membrane potential and be a little bit more negative than it is at rest, right? Eventually, it's going to reach its resting membrane potential, and it's going to stay there until it's depolarized again. And this period in between here, this is going to come in handy when we talk about cardiac dysrhythmias. Trust me. This right here is the absolute refractory period. And during the absolute refractory period, this means that the cell cannot receive another impulse until it's repolarized, right? But then eventually it's going to coming to this other section here. It's going to be the relative refractory period where it's still, the cell's still getting ready for another potential, but it still can be depolarized if if an impulse is transmitted during this time. It's just not at rest, right? So absolute refractory period can't receive another signal. Relative refractory period can receive another signal, but it's not technically ready to receive another signal. And the important part about that, in the context again of emergency medicine, right, is if you get another depolarization, another signal during the relative refractory period, you can cause someone to fall into a really dangerous and or deadly cardiac dysrhythmia. And the importance of what I just talked about in the context of one of our main diagnostic tools, which is the EKG, as far as the relative refractory period and there being a signal transmitted to the cardiac myocyte during this relative refractory period being a bad thing, right? What this means in the terms of analyzing this on our EKG, this means that, so during repolarization, right, cells repolarizing, hyperrepolarizing, that is your T wave. That's how we notice that on EKG is our T wave. Cells repolarizing, right? So if you get a signal on the T wave, which is called an R on T phenomenon, you can throw someone into VFib or VTAC, which are two very deadly cardiac dysrhythmias. So I thought I would mention there, since we're on the topic of refractory periods and what that all means. But anyways, let's move on. All right, so we talked about the conduction system. We talked about the action potential. Now let's just put it all together so we understand what's going on in the QRS before we start talking about dysrhythmias, which we will talk about very shortly. So again, what's the P wave mean? Atrial depolarization, left and right atria, atrial contraction, right? PR segment, little pause, AV node, holding onto that electrical impulse. QRS, ventricular depolarization, leading to ventricular contraction, right? ST segment, this period of time from the S wave, bottom of the S wave, to the T wave. This is all part of repolarization. T wave is your repolarization and or hyperrepolarization as well. We'll talk about the ST segment later on, because the ST segment is very important when analyzing EKGs and cardiac rhythms. And anyways, last thing we got to talk about here is this is your QT interval, right? And this is another point of measurement we use when analyzing EKGs to detect abnormalities like prolonged QT syndrome. When you have a prolonged QT, bad things can happen. Not good, not good. And this can lead to some really, really serious cardiac dysrhythmias, such as like Torsades de Pointes or other ones that we will talk about later on. So just keep that in mind. And again, this is our PR interval from the beginning of the P to the beginning of the QRS, right? To the beginning of the Q. So before we move on to EKGs, I have one more thing to talk about, and that would be I'm going to give you the normal measurements for each one of these measurements that we take here, or each one of these things here, because how you read an EKG is making sure that everything's within the proper parameters. Each one of these sections has the proper measurements. So the PR interval, normal PR interval, is between 0.12 and 0.2 milliseconds, right? And PR segment, that's not something we typically measure. Maybe cardiologists measure the PR segment in particular, but usually we just measure the PR interval if you're not specializing in that and you're not a doctor. But and then as far as a QRS, a normal QRS is below 0.12 milliseconds, right? So 0.12 milliseconds would look like the distance from here to here. And it would be 3 little boxes. Remember, each box is 0.04 milliseconds, and you want to be under 0.12 milliseconds before you consider it abnormal and or wide, right? And then as far as your QT interval, normal length of QT intervals, it's 0.44 milliseconds for a man and 0.43 milliseconds for a woman. So your QT interval should be at least that, or at least shorter than that, right? T-waves can vary in size depending on electrolyte imbalances, if someone's dehydrated, things like that. So there isn't a specific measurement for that, but if someone has for example, like a peak T-wave, that can mean like a hyperkalemia, electrolyte derangement of some sort. And your ST segment, since we're already talking about it, from here, well, this right here is your J point. So this diagram's a little off. So this right here is your ST segment, right here, right? This is your J point, right? If this ST segment is raised one little box, 1 millimeter, right? 1 millimeter above the isoelectric line, we got a problem. That would be indicating a heart attack. There are other things that cause ST segment elevation, such as other cardiac abnormalities, such as ventricular hypertrophies. But in general, if you have ST segment elevation, it's typically not a great sign. Either someone has some sort of deeper underlying pathology, or if that's a new thing, it could potentially mean that they're having a myocardial infarction. So now that we've gone over the QRS complex and we understand the proper measurements for each component of the QRS complex and what they mean, let's get into talking about different cardiac rhythms. I just wanted to jump back in here after rewatching this and say that I accidentally misspoke when I was talking about the QT interval. The actual values that you need to have for a QT interval to be technically within normal is 0.45 milliseconds for a man and 0.46 milliseconds for a woman. So just keep that in mind when you're measuring your QT interval. All right. So before we start talking about cardiac dysrhythmias and how to read a 12 lead with a cardiac dysrhythmia and how to analyze it, let's take a look at a normal sinus rhythm first. Perfect normal sinus rhythm, right? So this right here is a fantastic example. I know we don't have a 12 lead, but we can just take at least a look at this one lead right here for reference. So I'm just going to teach you real quick how I read a 12 lead. This is how I taught, and I think this is the way that most people read 12 lead. So first thing I'm looking at when I take a look at this EKG strip, I'm taking a look at, does it have a P wave for every QRS, and is there a QRS for every P wave, right? We're not dropping complexes. There's no lone P waves here, or there's no segments where you don't have a P wave and you just have a QRS. Looks fantastic. All right, cool, right? So the next thing I'm looking at is it narrow or wide? It is narrow. It's below 0.12 milliseconds, our normal parameter for when we consider it to be abnormal and or potentially ventricular, or there's like a bundle branch block there or something else causing QRS widening. Could be electrolyte derangement too. There's a lot of causes, right? So this one right here, it is about, let's say, it's about around 0.08 milliseconds, so fantastic. It's narrow, right? What's the rate here? So this is how I count. This is how I count the rate for my EKGs typically. So each one of these boxes, these big boxes, this is 300. This would be equal to 300 if there's a QRS at the beginning of this big box, and there's a QRS after one of these boxes. That'd be 300, right? So, and then we count down from there, and I'll show you how. So right here. I know it's not perfectly at the edge of this, so just bear with me here. So I go 300, 150, 100, 75, 60, right? And so it'd be 60 if one QRS is here and one QRS is here, right? Exactly 60. So now that I know it's a little bit before 75, right? Or a little bit after 75, excuse me. It's probably about 70 beats per minute since this is pushed up. Yeah, so the rate looks good. It's between 60 and 100. Fantastic. Rate is great. And is it regular, right? Are all of these QRSs evenly spaced out? And to me, they look like they are. And a really good trick for measuring regularity of a rhythm, if you got some time, and it takes literally like 1 second, sometimes there's little cards that have markings on them that you can use to test this, or you can take a sticky note or a piece of paper and just mark with your Sharpie and put it over the 12 lead or the lead you're looking at, and mark where your QRSs are on that piece of blank paper, and then move them to measure other distances between other complexes. And and if they match up the same, you're fantastic. Everything's regular. And if they don't, it's irregular. All right, and after we check the regularity, this is regular. It's fantastic. We take a look at the PRI, right? So again, our PRI starts right here, ends right here, at the beginning of the Q wave, and we want it between 0.12 milliseconds and 0.2 milliseconds, and this, we can already tell, this is perfect, right? It's smaller than this big box, and this big box total is 0.2 milliseconds, and this is about, I would say, about a box short of that, so it's about 0.16. This is great because you got a little here and you got a little here, 0.16. Fantastic, right? And then let's take a look at our QT, and let's remember our normal parameters for QT are 0.45 or below for men, 0.45 milliseconds, or 0.46 milliseconds for women, below that. Our QT, beginning of the Q wave, to the end of the T wave, right? This I can tell that it's smaller than these two boxes, so we're in the clear right here, right? Because this box and this box together would be 0.4. I can make it easier on myself by using these little landmarks, and it makes reading EKGs a lot faster and a lot less tedious, and you're still not going to miss anything if you use these parameters, right? And then let's take a look at abnormalities. I know I have them listed here, and we'll get into more of that later, but here's a fantastic example, right? This is a very basic skill you need while reading EKGs as a paramedic, and every paramedic should be able to recognize this, right? Let's take a look at ST segment elevation, right? So I have this upward deflecting QRS, right? So this would be ST segment elevation. If this S wave, instead of going down when it's hyperpolarizing, cardiac myocyte, it would go, bam, right there, into this T wave. That would be ST segment elevation, and the specific criteria we're looking at for ST segment elevation would be 1 millimeter, right? But I know this really tripped me up when I was first reading EKGs, and it still trips up a lot of people in general. And actually, doctors argue about the significance of what I'm about to talk about right here. So remember how I said that this is the J point, right? Sometimes you can have just an elevated J point. So this segment right here, part of the ST segment, this J point, let's say it's up here, right? You have J point elevation, right? But that's not true ST segment elevation because it's going down. And it's going down, and the J point's just elevated, not the whole segment, right? Segment elevation, very bad. Have that in 2 contiguous leads, and we'll talk about what that means later. Very, very bad. J point elevation, not good, honestly. It can be very benign, right? But it can be indicative of a more sinister cardiac condition. Sometimes J point elevation in multiple leads can indicate some sort of cardiac ischemia or infarction, but that situation is a lot fewer and far between. And there's a lot of benign conditions that cause J point elevation that don't indicate an emergency, right? But anyways, now that we understand what normal sinus rhythm looks like and we know how to read a 12 lead, let's move on and start talking about some dysrhythmias and talk about what we're here for. So for our next rhythm that we're going to analyze, we have sinus bradycardia here. And so basically, sinus bradycardia, the only way it differs from normal sinus rhythm, from a perfectly normal rhythm, is that the rate is just slower. It's at 60 beats. It's less than 60 beats per minute. So we can take a look at this example of sinus bradycardia here, and we can tell by counting the boxes that we have about 50 or 51 beats per minute. Probably about 51 beats per minute, because this QRS is right to the right of this box, right? But everything else about it is normal. PRI is fine. There's still a P wave here. QRS is normal. We know that it's coming, that the electrical impulse is still coming from the SA node, right? The only difference is it's just the impulses are coming at a much slower rate. And potential causes of sinus bradycardia are things that would cause the SA node to have some sort of dysfunction or to slow down. And these causes would look like drug overdoses, like beta blocker overdose or any nodal blocker overdose, or you maybe just take one too many of your daily beta blocker, like you took an extra propranolol because you couldn't remember, that type of thing. Or you could have a digoxin toxicity. You might see this with someone that's taking digoxin because they have congestive heart failure, right? Digoxin causes increased inotropy. You get a better cardiac output, or it would be good for someone with congestive heart failure potentially. And say that they took their digoxin in the morning, right? And an hour goes by and they were talking on the phone and they're just like, did I really take my medication? And then they take another digoxin, right? You end up with, say, sinus bradycardia if it doesn't throw them into something else because they took too much digoxin. That's entirely possible. Another potential cause of sinus bradycardia could be a head injury, right? Because if you have increased ICP, right, you have a bleed. Someone has like some sort of bleed, right, and it's causing more pressure in their skull, in the intracranial space. It increases vagal tone. It starts pushing on the vagus nerve, which eventually attaches. It's one of the cranial nerves, attaches to the brainstem. That's where your respiratory drive is, and increases the vagal tone by pushing on it, and it causes the release of more acetylcholine, right? And what does acetylcholine do? Acetylcholine causes the SA is released and causes the SA node to beat at a slower rate. It puts it in rest and digest, even when it shouldn't be, right? So this could potentially affect our cardiac output in a patient and could be potentially dangerous. So there are some situations where you might need to speed it up if they are symptomatic, and you might need to give a patient something like atropine, or if they are really decompensated and they're hypotensive, systolic blood pressure less than 90, they're altered, they're drooling on themselves, maybe they're completely unconscious, might have to pace them, right? And artificially send artificial signals to their cardiac tissue to generate heartbeats. But anyways, let's move on to the next one. All right, so here we have sinus tachycardia, and the only difference between sinus tachycardia and normal sinus rhythm is that sinus tachycardia is a sinus rhythm beating of over 100 beats per minute. And this one right here, we can quickly tell that this is about, I would say, about 140 beats a minute, maybe a little bit less, right? Still got a P wave. It's still a narrow QRS. Fits all of our other criteria. It's sinus. We know that the electrical conduction is coming from the SA node. We know this is sinus tachycardia, 100%. It's regular. It looks regular to me. Sinus tachycardia is a narrow, regular rhythm, heart rate over 100. If sinus tachycardia looked irregular, it might not actually be irregular. You might just have like a couple PACs thrown in here, right? A premature atrial complex, meaning that one of these QRSs and a P wave might come a little bit early, right? That'd be a PAC. You just get a premature electrical signal, right? Or you might have a PVC, right? You might have a premature ventricular complex. You might have a one random big ol' QRS, wide QRS thrown in here. A wide QRS with no P wave, wide QRS with no P wave. That would be a PVC, and that might make this look irregular, right? But it might still be a regular sinus tachycardia. And typical causes of sinus tachycardia, the number one I would have in my mind is the patient's probably dehydrated. Dehydration's a massive cause. They're not malnutrition in general. They're not eating enough, and they're not drinking enough water. Easily have someone in sinus tachycardia at rest, right? Someone's in sinus tachycardia at rest. The only things I'd be thinking about would just be what potentially could this be causing. Because sinus tachycardia itself isn't typically an issue, even at rest. It's a symptom of something else. I'd be also thinking about, is the person sick, right? Have they been sick recently? Do they have a fever, right? Because people who are sick and have a fever, sinus tachycardia absolutely be a part of that. It could be that could just be one indication that they're septic, right? They got a temperature of like they got a 102 degree fever and they have a heart rate of 130. They're probably not doing too hot. Other causes other than dehydration, some sort of sepsis going on, and sepsis and dehydration could absolutely be a part of that sepsis, making sinus tachycardia worse. People that are septic are typically dehydrated. Among other issues going on there, right? Drugs can cause this, cause sinus tachycardia in general, like sympathomimetic drugs like crack, meth, ecstasy, Molly, things like that absolutely cause sinus tachycardia. People's prescription sympathomimetic medications like Adderall, Vyvanse, Excedrin, all of those things cause sinus tachycardia, 100%. Caffeine, that's a huge one. Caffeine causes sinus tachycardia. Same with just anxiety in general. If someone has a history of anxiety and they seem anxious and they got sinus tachycardia on the monitor and they're like, why is my heart beating so fast? It's probably just because they're anxious. There's a lot of causes of sinus tachycardia in general, but typically sinus tachycardia isn't the main issue when you see sinus tachycardia on the monitor. It's a symptom of something else. It's simple as that.
All right, so the rhythm we're looking at here is SVT, also known as supraventricular tachycardia, or PSVT. And PSVT stands for paroxysmal supraventricular tachycardia. The only difference between these two is that one of them, PSVT, by definition, starts and stops abruptly and is more episodic. So, like, if this SVT right here converted into normal sinus rhythm out of nowhere, that would be an example of PSVT. This specific type of PSVT we got here is AVNRT, also known as atrioventricular nodal reentry tachycardia. So this tachycardia, or this supraventricular tachycardia, operates via a reentry pathway, right? And supraventricular tachycardia in general just means a tachycardia that originates above the ventricles. And AVNRT, atrioventricular nodal reentry tachycardia, is a supraventricular tachycardia that involves the AV node, right? That's our location of our reentry circuit. And what happens is our normal electrical conduction signal moves down the internodal tracts of the atria and meets the AV node, right? But this AV node in a patient that has AVNRT is going to be altered. One reason may be genetics. Another reason may be some sort of scarring of the AV node from one pathology or another, right? And what this does is it creates an AV node where the center of the AV node it's unusable. Electrical impulses cannot go through the center of the AV node, so it creates this little donut essentially where there's two sides. There's two sides of the AV node that are full of excitable tissue that connect back to the normal tract going towards the bundle of his, right? So what happens is that this electrical impulse that's going orthodromically or normally down through the conduction system meets the AV node, right? And it tries to go through both ways, but it can't. One side of the AV node, one part of the ring of the AV node blocks the impulse. It doesn't allow it to go down that direction through the AV node. So it chooses to go down the other side, right? And what's interesting about this tissue in the side that it chooses to go down is that tissue, it doesn't function like normal nodal tissue would. Instead of depolarizing or repolarizing at the same rate that it normally would, it depolarizes faster and it repolarizes a lot slower, right? And so this electrical impulse is rapidly transmitted down the side of the reentry pathway, right? And the electrical signal's now at the bottom of the AV node. But there's still another side of the AV node. And the other side of the AV node, even though it doesn't orthodromically take electrical signaling, it does in a retrograde fashion. So this impulse is now at the bottom of the AV node, and it's next to two sets of excitable tissue. One side of the AV node that's left, the other side that we didn't use, and the normal electrical conduction pathway going down to the bundle of his. So it goes down both, right? It sends a signal to the ventricles, but it also goes through this. It goes back through, it re-enters the AV node. This is why it's called a re-entry pathway, right? And in this side of the AV node, the tissue functions a little bit differently than the other side. It repolarizes really, really fast, and it depolarizes really slow. So this signal is brought back up to the top of the AV node, and it's caught in this loop, rapidly shooting signals down into the ventricles, right? So what this does is it causes rapid ventricular contraction and rapid atrial contraction, and you get no preload of the heart. You get no time to fill the atria of the ventricles with blood, which means that you're going to get a really bad cardiac output, which is going to cause a lot of problems for the patient, right? Their tissues are not going to be perfused the way that they should be, and their blood pressure is going to drop. And you guys know what's going to happen from there. It's not going to be good. You can't sustain life in a state like that, right? But SVT, though it is dangerous, it's not quite as deadly as it's not as deadly in general as something like VTAC or VFib, right? Someone can be in SVT for a while, though it's not going to look pretty. It's going to be really uncomfortable, but they can be in it for a little bit, for a while before they start to decompensate, right? But anyways, the way that we recognize AV-NRT on a 12 lead would be, let's just take a look at these complexes, right? So they're narrow, right? I don't see a P wave anywhere here. I see a T wave, but I don't see any P waves here, right? So AV-NRT, this type of supraventricular tachycardia, normally doesn't have a P wave, right? Because of where it's located at. With AV-NRT, because of it re-entering, you might see a retrograde P wave, right, on the other side of the QRS, but you're not going to see a normal P wave in front of the QRS, right? So if we don't see a P wave, and we see a P wave that's retrograde after the QRS, and it's narrow like this at a rate of 150 or greater, right, then it's probably AV-NRT. But AV-NRT won't always present like this. You can have slight variations, and it might look a little bit differently. But generally, if you have a narrow rate over 150 with no P wave, it's AV-NRT, and this can be treated with. This is usually treated with medications such as beta blockers or calcium channel blockers. First line medications, though, for AV-NRT would be like adenosine. That's a really common one in the pre-hospital setting that people use to slow this rhythm down and hopefully throw the patient out of it. And the whole idea with beta blockers and calcium channel blockers, the reason why we're giving them for this rate is because they extend atrial refractory times. So meaning that the tissue
has a longer time where it's not excitable. And what that means is that when that impulse goes back to the bottom of the reentry pathway, the bottom of the reentry circuit, it can't go back up into it. It can't reenter because that tissue is still not usable. It's still in its refractory period. It's still resting. So the impulse then just shoots down to the ventricles, and electrical conduction carries on as it normally would. And you have great cardiac output, right? So that's the whole idea behind those two little things I figured I'd throw a pearl in, right? But just remember that AVNRT isn't always going to present, it's not always going to present looking exactly like this, but generally narrow QRS, no P wave or retrograde P wave, and a rate over 150, it's going to be AVNRT. Right, so this is a really unique type of SVT. It's called AVRT, atrioventricular reciprocating tachycardia, also known as WPW. And what's going on here is patients with WPW have what's called an accessory pathway, specifically called the bundle of Kent. And what this does is it allows electrical signal from the atria to go directly into the ventricles through the accessory pathway without completely bypassing the AV node entirely. And why this is significant, as we talked about the AV node earlier, is what the AV node does is it gets an electrical impulse originating in the atria, and it holds onto it for a second. It slows it down and then releases it to his Purkinje system, leading to ventricular contraction, right? It's the regulator of impulses from the atria to the ventricles. And without this regulator on this accessory pathway, this is going to lead to some really, really rapid transmission of electricity into the ventricles, leading to a very rapid ventricular rate and a rapid heart rate in general. And what this is going to do is it's going to make your EKG look really, really weird. So for pre-excitation WPW, which is just one of the three types of WPW, it's going to work just how I explained it. And the reason why your QRS is going to look like this, per se, is because of that signal reaching the ventricles at the same time as it's going to reach the AV node. So it's going to cause this QRS to widen out, and you're going to have a shorter PRI interval, right? And remember what we talked about PVCs earlier? Impulses originating in the ventricles are going to cause a wide presentation of the QRS. Ventricular rhythms are typically wide. So if this impulse is reaching the ventricles at the same time as it's reaching the AV node, it's going to cause the QRS to widen out and the PRI to shorten, right? So let's go over here and talk about antidromic AVRT for a second. Antidromic AVRT is going to present a little bit differently. Instead of a short PRI, you're going to get what's called a delta wave. And a delta wave is that PRI segment just meshing in to the QRS essentially. It's going to look like a wizard finger. That's what I like to call it. And there's not going to be a P wave. It's also going to be wide though. And the reason why it's going to look differently than pre-excitation WPW is just the way that the electrical conduction is moving, right? So what this is going to do, what the SA node is going to do, or any impulse originating from a foci, the SA node, from the atria, doesn't matter. It's going to go through the accessory pathway first, not the AV node in the ventricles at the same time. It's going to go through the accessory pathway first into the ventricles, and then move antidromically up through the AV node. I said retrogradely up through the AV node and get caught in a reentry circuit going this way. And this is what's going to cause your wide QRS and your delta wave, and there's not going to be a P wave. But orthodromic AVRT, the way that this is going to work is you're going to have electrical conduction moving in an orthodromic fashion. So anterograde conduction through the atrioventricular node. It's going to move down through the AV node and then back up through the accessory pathway. It's not going to be choosing the accessory pathway first. And what this is going to cause is it's going to cause a narrow QRS and a retrograde P wave. So it's going to present pretty much exactly the same as AVNRT. It's going to be indistinguishable. It's just there's a different mechanism going on there, right? And one more thing I wanted to add about WPW and the dangers of it in general are if you have someone in atrial fibrillation with WPW, it can lead to some really scary rhythms, right? Especially with someone with pre-excitation WPW, because if they have a bunch of foci firing off in the atria, which we'll talk about later, these signals can go directly into the ventricles and cause the ventricles to fibrillate too, leading to ventricular fibrillation and sudden cardiac arrest. And sudden cardiac arrest is a big concern with WPW in general. But anyways, let's move on to actually looking at an EKG with WPW on it, so we can have a better understanding of what it looks like and how to identify it. All right, so this is our EKG example of WPW, and specifically this is anadromic WPW, and we can tell it's anadromic WPW by two characteristics here. So we have our delta wave going into our QRS, delta wave, and our wide QRS. And then let's take a look at our rate. Our rate is about 290, 300 beats a minute, something within that range, right? So this person's heart is definitely not happy at all, right? So what are we going to do when we treat this patient? So number one, medications that we should be thinking about when treating a patient with WPW would be class 1 antidysrhythmics such as sodium channel blockers. Procainamide, flecainide, lidocaine, those are all good to treat WPW. Class 3 antidysrhythmics such as potassium channel blockers like amiodarone can also treat WPW. Medications that I really want to avoid with WPW and that I should never be giving to WPW in any circumstance, if I can recognize this rhythm, would be nodal blockers such as beta blockers and calcium channel blockers. And the reason for this is when you give a nodal blocker, like a calcium channel blocker or a beta blocker, you're going to slow down the conduction of the AV node, right? Because that's what nodal blockers are doing in the context of cardiac dysrhythmias. You're slowing down the conduction of the AV node. And what this is going to do potentially is it's going to enhance the aberrant pathway, the accessory pathway causing the WPW, and it's going to cause this WPW to beat at an even faster rate, and you're going to increase your likelihood of an R on T phenomenon and send this patient to VFib and kill him. So don't use a nodal blocker with WPW. You never should use a nodal blocker with WPW. You're probably going to kill your patient if you do it. Another situation where you should definitely not give a nodal blocker to WPW would be AFib with WPW. And the whole danger behind this is that with someone with AFib and WPW is you're going to slow that conduction of the AV node, right? And then you're going to get one-to-one atrial fibrillation conduction from the atria to the ventricles through the accessory pathway, through that aberrant pathway, and you're going to send that patient directly into VFib and kill them very quickly. So let's avoid those medications and let's stick to our sodium channel blockers and potassium channel blockers for WPW. And if we're not using medication to treat this rhythm, we're definitely going to be shocking this rhythm. I just wanted to add one more thing. If you see this rhythm on a monitor and the patient is decompensated and they're clinically hypotensive and they're symptomatic, cardiovert this thing immediately, because you should not play around with medications, in my opinion. If the patient is decompensated, they're drooling all over themselves, and they're hypotensive, and you see a rhythm like this on the monitor, this should give grounds for a pretty much instant cardioversion. Get the pads on and treat that patient right away. All right, so this is atrial fibrillation. Atrial fibrillation is by far going to be the most common cardiac dysrhythmia you come across in your career. Atrial fibrillation is a narrow complex tachycardia that is irregular and supraventricular of origin. Atrial fibrillation being supraventricular of origin means that, like we talked about before, it originates from the left and right atria above the ventricles. Atrial fibrillation has two main causes. The first cause of atrial fibrillation is multiple different groups of ectopic foci in the left and right atria, which are groups of cardiac pacemaker cells with abnormal electrical activity that rapidly fire off impulses to the AV node at a very high rate. So this causes the atria to contract or beat at rates of 300 to 600 beats per minute. And they don't really contract, they fibrillate, hence the name atrial fibrillation, which is kind of like a seizing or quivering type motion, which causes the blood to pool in the left and right atria as they are not able to contract, they quiver, and very little blood is kicked to the ventricles to be pumped into systemic circulation. So this leads to issues such as a reduced cardiac output. It also leads to an issue of blood clots, because if the blood is just sitting there and not really moving, it starts to coagulate, and blood clots can be a really scary issue as a result of atrial fibrillation. Atrial fibrillation can also cause a rapid ventricular rate from all of the fibrillation impulses in the atria, because the AV node can only slow down impulses to the ventricles so much. So this can cause the ventricles to beat at a very rapid rate as well. And when they're beating at a rapid rate, it's called AFib RVR. AFib RVR by definition is AFib with a rate of above 100 beats per minute. AFib can also be caused by different micro reentry circuits, which are located in the upper left atria near where the pulmonary vein connects to the left atria. And just like the foci, there would be a bunch of these little reentry circuits firing off very, very rapidly, causing the atria to quiver, and the same issues to be caused just like that the foci caused. And the creation of these foci and reentry circuits is typically the result of a concept called atrial remodeling. And basically what atrial remodeling is in short is the destruction or damage of normal cardiac tissue, right, from other pathologies such as heart failure, mitral stenosis, valvular heart disease, hypertension, atrial enlargement, things that cause damage to cardiac tissue or atrial tissue and stretch the tissue, typically can set the heart up to develop these micro reentry circuits or these foci, which cause atrial fibrillation. Although atrial remodeling plays a really big part in the creation of foci and micro reentry circuits, bouts of AFib and episodes of AFib are usually set off by a combination of things. So you'll have atrial modeling that occurs in someone due to hypertension, right atrial enlargement per se, mixed with the patient having a fever, being sick, and that causes their first bout of AFib, or they have hyperthyroidism, so their increased sympathetic tone causes a bout of AFib mixed with the reentry circuits there that they already have created from the atrial remodeling. Hypotension or hypoxia can put someone in a state where atrial fibrillation is likely if they already have this atrial remodeling done. Genetics can also play a factor into the development of AFib. So there are a lot of different causes of AFib, but they all end up with the same result and the same risks that come with atrial fibrillation, which would be the creation of blood clots from blood pooling in the left and right atria because it's sitting there because of the fibrillating atria, and the decreased cardiac output if the ventricular rate becomes too high. If the ventricular rate is 150 plus, that could lead to some serious decrease in cardiac output and decreased cerebral perfusion and cardiac perfusion, which can put a patient in a very dangerous situation. So typical treatment or baseline treatment of atrial fibrillation would be with like a calcium channel blocker or a beta blocker. Those are usually used to treat atrial fibrillation because they slow conduction of the AV node, which helps avoid a rapid ventricular rate. If someone is having a bout of atrial fibrillation, they got a heart rate above 150 and they're hypotensive, that right there is grounds for electrical cardioversion. Electrical cardioversion, not chemical cardioversion, because if the patient's unstable, you want to shock them and you want to bring up their pressure as fast as you can. You don't want to mess around with giving them cardizem or a beta blocker with their blood pressures that low, especially because those medications will drop their blood pressure even further. If their blood pressure is kind of on the border, like around 100 systolic or 110 systolic per se, and you're worried about the diltiazem and or cardizem dropping their blood pressure, you can go ahead and give them a gram of calcium if it's within your protocol while you're giving the diltiazem to avoid this drop in blood pressure. On the next slide, we'll briefly be looking over an EKG of atrial fibrillation and further how to identify it. All right, so this is our example of a 12 lead with AFib RVR. So let's read it real quick. So do we have any P waves here? No, we do not have P waves here. I do not see any P waves here. I see some T waves, but no P waves, right? It looks like the line is squiggly in front of the QRSs. It could be indication of atrial fibrillation. The rate is about rate is about 160. It is irregular. These are not, all the QRSs are not evenly spaced out. The complex is narrow. There's no PRI since there's no P wave here. The QT isn't prolonged or anything because this is rapid. The QT looks fine. And yeah, I see a PVC here, but that's about it. And this is this is definitely AFib. It's narrow complex, it's irregular, and there's no P waves. So this is AFib RVR in a nutshell with a rate of about 160. All right, so the next rhythm we're going to be talking about and discussing is atrial flutter. And atrial flutter is basically another reentry circuit tachycardia. And this reentry circuit is a very massive reentry circuit that pretty much takes up the whole right atria. It's called the cavo-tricuspid isthmus, and it goes through the SA node, through the AV node, back to the sinus node. And it has the same concept of one side depolarizes fast, repolarizes slow, and one side repolarizes fast, depolarizes slow. So this impulse gets caught in a rapid cycle, which creates what's called flutter waves in the both atria, and it causes the atria to flutter, hence the name a flutter. And the atria don't fibrillate; they don't beat quite as fast as they would in atrial fibrillation, but they beat at a rate of about 250 to 300 beats per minute. These flutter waves, and these flutter waves in general don't provide the same atrial kick that normal contraction does. So you have some of the same issues that you would with atrial fibrillation, just not to as a dramatic degree as far as coagulation and the creation of blood clots, but blood still is pooling here at a rate that it shouldn't be. But what this also causes is it causes a rapid ventricular rate, because if you have your atria beating at 250 to 300 beats per minute, it's going to cause the ventricles to beat extremely rapidly too, at a rate where cardiac output is going to be diminished very, very significantly. Potential causes of atrial flutter are similar to atrial fibrillation. The creation of this reentry circuit is largely due to the concept of atrial remodeling and the change in cardiac tissue due to other pathologies. Bouts of atrial flutter are usually set off by this concept of change in cardiac tissue mixed with circumstantial things like a fever, hypertension, increased sympathetic tone due to hyperthyroidism, hypoxemia, things of that nature, and the combination of that with the remodeling causes that bout of atrial flutter. Now, you can have a couple different types of atrial flutter. You can have 3-to-1 atrial flutter, 2-to-1 atrial flutter, and 1-to-1 atrial flutter. And basically what this means is it just means how many times is the atria fluttering versus how many times are the ventricles contracting? Like how many signals are actually reaching the ventricles versus what's being produced in the atria. But you can also have atypical A flutter, which is a irregular A flutter, which is a non-regular A flutter, because typical A flutter is normally regular, but atypical A flutter is where you can have an alternating 3-to-1 conduction and an alternating 4-to-1 conduction, depending on how many flutter waves you have before you get a normal QRS. And when you have an atrial flutter, or you're treating a patient with an atrial flutter, you're going to treat it generally the same way as an atrial fibrillation and other supraventricular tachycardias. You're going to cardiovert if they are decompensated, and you're going to give them things like beta blockers or calcium channel blockers to help slow down the rate and or terminate the rhythm entirely and convert it into normal sinus rhythm, hopefully, or sinus tachycardia. And one thing that I thought I would add in, since we're still on the topic of A flutter and AFib, is if the rate is above 150, a rapid ventricular rate, and the patient is stable, typically the first line of medication, at least in the pre-hospital setting, is going to be adenosine. Especially so you could slow down this rhythm, because a lot of times if you have an A flutter that's above 150 or an AFib that's above 150, it's very hard to differentiate from an SVT, and you might look at it and be like, oh, that's an SVT, I'm going to give it adenosine and slow it down. So I would just keep that in mind. All right, and this is multifocal atrial tachycardia. This is the last rhythm I'm going to be analyzing and going over with you guys because I'm running out of time for my project, so let's quickly go over this. So multifocal atrial tachycardia is a supraventricular tachycardia or supraventricular in origin, meaning it originates in the atria, just like the other tachycardias we have gone over today. But basically, it stems from multiple foci within the left and right atria, hence the name multifocal atrial tachycardia. So you're getting this abnormal conduction from multiple different groups of foci within the atria, or abnormal pacemaker cells conducting irregular electrical activity. And so when you're looking at a rhythm of multifocal atrial tachycardia, or a lead, you're going to notice that the P wave is going to vary where it is. Your PRI is going to vary, and it's going to come in many different forms. So your P wave is going to look really very, very strange, depending on where these foci are located. And in order to get a diagnosis of multifocal atrial tachycardia, you have to have a variation of 3 different looking P waves in a single EKG strip, and that's how you recognize multifocal atrial tachycardia. This is going to be treated just like supraventricular tachycardia if the rate is above 150, and if the patient is unstable, we treat with electricity, and that is a standard pretty much anywhere. Although there is another type of atrial tachycardia that's just called focal atrial tachycardia, which means you have an atrial tachycardia that's stemming from just one foci, or just one group of abnormal pacemaker cells setting off a regular electrical activity. So you might get a P wave that looks very, very similar to a normal sinus P wave. It might be indistinguishable from a normal sinus P wave, but you have a heart rate of 160. So that's how focal atrial tachycardia can present, and you might not even know it's focal atrial tachycardia until the patient tells you that they had focal atrial tachycardia before, or you are working in a hospital and you have multiple different EKG strips to reference while you're looking at a patient's case. Anyways, thank you for sticking with me throughout this lecture, and I hope you learned a lot and hopefully had some of your questions answered by the information that I brought forth today. Thank you so much. Bye-bye.